Hi, everybody. Susan Clinton here with my co-host Erica Mello. This is Tough to Treat, and this is episode 129. And we
Mhm.
wanted to just pop in and hope everybody had a great summer. It is September now, and Erica and I both took some much needed time off, and we hope that everybody else also did some self-care and enjoyed a couple of rebroadcasting of our podcast. But we're back
Yeah.
today live, and we
Yes.
wanted to just pop in and say hello. Erica, anything you want to add before we head over?
Yes. No, once again, just hope everybody had a wonderful summer. And a couple of things we're going to we've now when you said 129, I was like, I know I keep saying this, but it's a lot of episodes. And so we're going to have some curated playlists available for people. And it's because we've done so many topics over the years, and I know we get new listeners all the time, and no one's going to have the time to go back and listen to episodes, every single episode. But if you're interested in like pelvic girdle pain or low back pain or shoulder pain, you can type on our website toughtotreat.com, and all the episodes will come up. But we'll also give you a list that'll be coming in the next few weeks of episodes devoted to that particular topic, so it'll be easier for you to sort of listen when you want as well. And our toughtotreat.com website still is we're still rocking it on the website, so to speak. We've had a lot of new people sign up for the newsletter, but I like the search feature, and I've used that myself. You type in knee pain, and there's like 8, 10, and 9 episodes, and you can easily click on and listen to them. So for those of you who haven't done that and haven't signed up, the URL is easy, toughtotreat.com.
Yes, and I think that's important. We want to be able to share the playlist with you when it comes out, so definitely get on our email list. That's where you're going to find most of our best offers and things that we're kind of planning for the fall and into the winter. Also, it's the playlist is going to work kind of like what you see with journals. It's going to be like the collections tab.
Yeah.
So, if you look at, really good journals out there, they have a collections tab, and underneath it, you see the subject, and you see all of the journal articles from that journal on that subject there, and that's exactly how we're designing the playlist. So
Yeah.
we'd love to share it with you. If you're not on our email list, hop on there. So
Yes, and we also have a couple PDFs for free for anybody who signs up. One is a Clinical Pearls PDF that I wrote. Obviously, on Clinical Pearls on tough to treat assessment and treatment. And Susan has a couple of fantastic PDFs on sleep and persistent pain, and it's both so very important in treating these tough patients. So head on over toughtotreat.com, and we hope you enjoy the episodes.
hi, everybody. Susan Clinton here. Tough to Treat with my co-host Erica Mello. Hi, Erica. How are you today?
I'm fine, Susan. How are you?
Doing
Happy
well.
September.
Yes, it's a rainy day in September for sure, both in New York and in Michigan. And but we're here and we're back live, and we're happy to be back live after the
Yes.
summer.
Yes.
I'm going to dive right in. This is
Let's do
a
it.
this is a client that I had a long while back, but I think it's an interesting take on looking at drivers and how one driver can really affect the other driver when we don't have something very clear cut going on. This is a 57-year-old female who presented with low back pain and gradual onset of stress urinary incontinence. And kind of an interesting history. She took a fall 2 years ago on the ice onto both of her hands and her knees,
Mm.
and hit the left knee a little harder than the right knee, and kind of had some wrist stuff going on from it, and says that everything all cleared up and she's all fine. A history of a clavicle fracture on the right from 3 or 4 years before falling off of a bike. So a couple of, I think interesting, we talk a lot about history,
Yep.
trauma history.
Yep.
And, it was interesting because she was telling me that her mild stress urinary incontinence, kind of it just kind of came on slowly. And when I really questioned her, it actually started 2 years ago, right after
Mm.
her fall.
The fall on the hands and knees, or
Yeah,
the fall.
yeah, which is interesting for the people out there with pelvic health, is because we usually see, stress urinary incontinence happen, kind of along the way after childbirth, whatever, nulliparous women because they're running and jumping, different things. But this one was definitely there was no issues until after this fall. So I thought that was pretty significant. That shows how
Yes.
kind of like a kaboom that fall might have been.
Yes. Yes.
You know, she's been to her gynecologist. She doesn't have any problems with prolapse. She doesn't have any kind of pain. She doesn't have pain with sex, you know, just this mild SUI that gets worse if she has a full bladder. If she's going to be walking long distances, she notices that after she's been walking for a while, she really starts to feel like I kind of need to like start to find a bathroom, you know. And if she said if I was to like, you know, jump or hop, I would definitely feel vulnerable. And this has all been going on for the last 2 years. So it was interesting with her kind of connecting the dots just a little bit, because she just really didn't put that together.
Yeah.
And it said, you know, could be coincidence, but you know, you didn't have any issues until this happened. And I
Yeah.
said, falls can be pretty traumatic. That can have a lot of reverberations through the body that we don't expect. You know, I've heard of people, you know, fracturing teeth, you know, from falling down really hard. I mean, there's a
Yeah.
lot of things that can happen.
And her clavicle fracture, the fall off the bike, how long before this recent fall?
About 3 or 4 years before.
Oh, before you.
No,
Okay.
before she came to see me. So
Okay, so just a year prior to the other.
a year or two prior. She wasn't clear on the date.
Okay. It's so interesting you say that too, because people are like, you know, because we spend a lot of time in the narrative getting their story. And they're like, well, why do you care about my clavicle fracture as an example, or my ankle fracture when I was 15? I'm like, I'll tell you why. Because your first injury sets you up, and then your movement pattern keeps you there. Your dominant movement pattern.
Yeah, it becomes a dominant pattern as you adapt.
Yep. Yeah.
So looking at her low back stuff, she definitely had an extension pattern. She feels better with flexion, worse with extension. So walking bothers her, you know, reaching up bothers her. You know, she's 57. So you start kind of thinking, gosh, is that like a literal lateral? I can't even think of the word.
Then worse with extension?
Some lateral stenosis.
Got
I
it.
think of the word, you know, on one side. But, you know, and flexion did feel better, you know, so if she is hurting and she sits down, she feels better. So, but it doesn't really matter really what the pathology is. At this point. This is, you know, the movement system is what I'm going to be working with her.
Yeah.
So I just thought I'd put that out there a little bit like that she doesn't like to extend back. That bothers her. Walking longer distances bothers her. No pain in the leg. Okay. No vascular or neurological claudication. It's really located. She can point right to it. She points right to that left side of L5, right over the left SI area, just that kind of lumbosacral area. No pain in the hip. You know, that's where the pain is. And it, you know, it's a dull ache, and it can get kind of sharp and irritable. And it has really gotten worse over the last few months. So, which is why she decided that she needed to do something about it, because it wasn't getting better. So her exam, when just standing there, you know, she stands with her left lower extremity kind of abducted and externally rotated. She's on the right side, as you can imagine.
Right.
And interesting, the right thorax is shifted right and rotated left. And so she's got that right shift of the thorax and a left rotation. So she's standing over on that right leg.
Yes.
You know, and, you know, so it kind of made me think, though, because there's that history of that right clavicular fracture.
Yep.
So when she squatted, she shifted right, stayed shifted right, and only could go halfway. You know, so we kind of started to look at that a little bit, you know, kind of thinking about that. When she did her bend, you know, just a straight bend over, her left knee stayed a little bit bent. So she still shifted, you know, to the right, but you could tell that, you know, and that the thorax it stayed rotated left sort of. So I'm not, you know, so I'm kind of like, well, is it because her thorax isn't going into straight flexion, is still rotating as she moves down?
Yeah.
Is that pulling her off, and that's why that knee isn't bent? What's going on here?
Right. Yeah. Something's pulling her to the right.
I haven't put my hands on her yet. So I'm just looking at this observation piece and kind of going from there. So let's see, when we did the standing on one leg, she was able to stand on the left lower extremity, but it bothered her. It increased her left lumbosacral pain. Makes sense, right? Because we're now forcing her onto the side that she really doesn't want to be on.
Yes.
You can stand on the right lower extremity, but again, that big shift is there with the thorax.
Yes, very common.
So,
Yep.
And so, of course, at this point, I'm like, okay, we put the hands on the wall. We got to see what we can do here.
Right. Yeah.
Narrow, regular, wide, just to kind of
Yes.
see what happens. She does get a little bit better. She still wants to really shift on the, on the right side when standing on the right leg. She still wants to
Okay.
really overshift on the right.
Mhm.
She was able to stand on the left leg easier with her hands on the wall.
Okay, and her hands in a
Yeah,
normal
just normal right
position.
there. She didn't have to go wide. She could stay
Yeah,
right there normal. To
got
to
it.
stand on the right lower extremity, without the shift, she had to really put her hands wide.
Ah, interesting.
Yeah, so she's a strong thoracic shift and the strong
Yes,
the
something
whole motor
above.
pat or the whole
Yeah.
motor system wants to stay over there.
Yes. Yes, yes,
So,
yes, yes.
yeah. Let's see. And
No,
then,
yeah, no, go ahead.
mhm.
No, I was gonna say when, yeah, that just clues me in that, thorax and above, and even our clavicle fracture. I'd put that on my magnet board.
Yeah. So, and just going back to the squat, I did have her do a normal stance squat and a wide squat, and she still stayed shifted to the right.
Okay.
And
So
it's
no
like
change.
it's like her foot on the left side stayed more supinated, and she was a little supinated on the right. Like she's already off on that right side, but it's kind of funny, the leg on the other side, you'd expect it to maybe pronate or
Yes.
come in with a little internal rotation. It kind of, the whole leg kind of stayed externally rotated, and so the foot was kind of up off the ground. So at
So,
that point, I put a towel underneath her heels. I'm thinking, okay, let's
mhm,
see if we've got a foot driver going on here.
mhm.
So when we put the towel that under her heels, it helped the squat a little bit. Like she didn't shift quite as much, so having the towel roll under both heels helped. And then I had her put her hands on the wall, and that helped a little bit too. So I decided, let's keep the towel there and let's really work on correcting this foot out of supination. So basically coming across the midfoot with my hand to bring her into a little bit more pronation, cueing her to keep her big toe on the ground.
Was she straightening her left knee out when you were doing that? Could she still straighten her left knee? Could she straighten her left knee out?
So as we kind of did it just standing, her knee was straight.
She got her knee straight.
Yeah, her knee was straight when we got that done. But when we went into the squat, everything got worse. The back got painful, which is interesting to me because the back was more painful in extension, and now we're going into
With the things
flexion.
under her heels, it got
Mhm.
worse.
Yeah, so it was better when we just had it under the heels.
Yes.
When we added the foot correction, everything got worse.
Okay, got it.
So
So that differentiates
yeah,
something to me.
yeah,
I
exactly.
know. I mean, I know. I think we're thinking the same thing.
Probably, probably. So we stopped doing that because it was like, okay, so if I take her out of supination, what's happening all the way up the chain?
Yeah.
And she tends to stand with that leg and right, and external rotation. And I'm thinking, okay, we've got a pelvic health issue problem here. I wonder if that she's probably got, what is it? Is it happening in the hip or is it happening in the knee? Because it's the foot. It's not the foot. The foot's the result.
Yeah. Yeah.
So I had to kind of look up the chain. And so that femur really likes to stay externally rotated.
Mhm.
So when I got onto her, so standing, I said, let's just do this. Don't think about your feet. I want you to think about just turning your knee just a little bit so that it like you're thinking about your kneecap turning to look at the wall.
Yeah.
Instead of this, instead of over here to the side of the room.
Mhm.
And I said, just leave your feet where they are. Don't pick them up and move them. Just start twisting and playing around with it. And I got on her thigh, and I actually kind of just like guided, a little internal rotation of the femur,
Mhm.
for her. And we started working with that, and it really started to show up as soon as she internally rotated her femur. The back pain got better, but she was unable to straighten her knee.
Okay. I gotcha.
Yeah.
Gotcha. Okay. And so did she still were her heels still elevated passively with the towels at that point?
I took everything away, so I thought, okay, let's just go back. I just wanted to get the foot completely out of the picture again.
Right. So when you had her feet very wide and in correcting the foot, no worse or no change. Okay.
Yeah.
Got that. Okay. Yep. And when you try to make some correction, in the leg, she's unable to straighten that left knee out.
The
Okay.
knee goes into flexion.
Yeah. So something doesn't like to be lengthened.
There's a real issue there.
Yeah.
So
Okay.
looking at her and kind of thinking about this, and of course we know we have this thoracic piece here
Yes.
that's
Yes.
not changing, doesn't change in a squat, doesn't change with bend over,
Mm-hmm.
does get better with hands on the wall. I thought, you know what, let's take the feet completely out of it and let's get her on our hands and knees
Mm-hmm.
and see what's going on here and
Yep.
see if it's really, it's going to keep the knee in a bent position, but I just wanted to see what would happen.
Yeah.
So I get her on her hands and knees, and it's interesting because the thorax does change. So we get the input coming through the arms, the thorax settles down a little bit. It's not as humped up and,
centered, more centered.
Yeah, starting to center out a little bit better. But what was interesting as she got on her hands and knees, the leg rotation was gone. That strong lateral rotation on the left.
Yes.
It was gone. So it was kind of like, okay, so we take the feet out of the picture. We also took the knee. Well, we have her on her knees, but they're bent.
Yeah.
So now I need to figure out how to kind of look at her, So I said, you know what, let's just go up into tall kneeling. I just wanted to just keep retesting, see what would happen.
Yeah.
Immediately the thorax shifted right again. And she got that rotation in her leg, not as bad as when she was standing. Okay, so something about that knee staying in flexion is important to her system.
Yeah.
We stood back up and I thought, let's just test this out a little bit here. I said, let's just see what happens if we leave the leg alone and we just kind of work on the thorax. So getting under the thorax, where you like to get, up high, close to, I'm thinking clavicle, first, second, third ribby, kind of stuff up there. I wonder what would happen if we just kind of like did a little breathing work there and did some shifting so she could kind of feel it. Arms on the wall, easy. And we just kept doing that and kept shifting till we could get that thorax to start moving. And when we got the thorax to start moving, we could actually then, once we could get the thorax moving back towards center a little bit, we could get the leg to come back underneath her body a little bit better. However, this knee still liked to stay slightly bent. So kind of thinking back to that fall she took on her hands and knees.
Yes.
There's something going on here. So this was the time that I got her on the bed. And, we started looking at the knee. First, I did a slump test. It was negative. Again, there isn't any, nothing that was making me think neural tension except the fact that this knee didn't want to stay straight when we got the rest of her body lined up.
Right.
And so what it turned out to be is that when she rotates her leg externally, she can straighten her knee. When she rotates the leg internally, and this showed up on the table laying on her back, when I rotated her internally, that knee bent every time. So there is some sort of posterior stiffness, in that knee that did not want internal rotation to happen. So it didn't, something in that fibular,
right,
or tibial, not tib fib, femoral tibial joint was not allowing her to rotate, internally there. So that incongruence there. So we played around with it. We did some things, I had her put her feet on the bed and we did some bridges, and worked on keeping her femurs still so that she wouldn't, kind of go out on the side of her foot on the left as she went out. And, we worked on some things that way to help just kind of build that symmetry back into her system. And I wanted the feet to be working with it. And then we kind of moved the feet out a little bit. And I actually finally got her to where her heels were on the bed. And then we started working on, can you lift your pelvis up, press down into your heels, and lift your pelvis up to see what would happen. And, just started working that way to get that to go. And then we took her back up onto her feet. And I did put the towel roll under her feet this time, under her heels this time,
Mm-hmm.
and she was able to get the legs straighter, but it required work to get the thorax in there.
I was
So
just going to ask that.
yeah,
Okay.
so we have,
Yeah.
so it just turned out with this person, we had this double driver. The
Yeah.
knee was driving the thorax and the thorax was driving the knee.
Like co-drivers. Yeah.
Yeah,
Yes.
which and here's, it was interesting because the low back was, being was really the part that was really having the issue, because it was constantly being rotated from above and rotated from below. And so eventually it just, decided that that was the area that it was going to produce. And she had done
Yeah.
all the exercises, all the flexion exercises. She had been mobilized, everything in her lumbar spine from before, and nothing ever really made it better because nobody was looking at that thorax and the knee together,
Right. And you put her in so many different positions too, like on the wall, on hands and knees, in high kneeling, and you see the same pattern, especially with the
Mhm.
thorax,
Yeah.
the same pattern showing up.
Mhm.
Then it's probably relevant,
And some things making a little bit of a difference, but other things not, so yeah, so we
Right.
just, so here's the thing, what do you do first? Do you treat the chicken or the egg? And to
Or
me it
do
was like,
both.
exactly, exactly, which is a point I wanted to bring up in the podcast, and I knew you would say that you have to do both.
Yeah.
I liked the bridging on her back because it put input into the thorax. You could also, like, she could have held put some TheraBand around her wrists, and she could
Hmm.
have like pulled gently there as she was
Doing the
bridging.
bridge.
One
Yep.
thing I forgot to tell you about the exam was when she went into lunges, she was unable to lunge onto her right leg because it gave her more left low back pain. Remember, she doesn't like extension.
Yes.
That makes
Yes.
sense, right?
Yes.
But then she
Yes.
was unable to lunge onto her left side, poor control,
Poor
just
control.
like
Okay.
falling all over the
Well, that
place.
makes sense because she's loading her right side. She's not
Yeah.
used to using her left. So,
When
yep.
we took her and did the bridge work, and then I took her standing, and we had the heel roll, the stuff underneath the heels.
Hmm.
We did some mini squats in that position to try to see, can we begin to like get the knees to like not go into so much external rotation, particularly on the left,
Yeah. Yeah.
and not do it from the feet, because that just made
Right.
everything worse.
Yeah.
And just kind of work out, so little mini squats to take the pressure off the knee, so it could stay bent. But could
Hmm.
we work internal rotation from there?
Yeah.
you know and so what we ended up doing, which was interesting, was I took her from there, I moved the towel roll away, I gave her two chairs to hold on to with her hands, and from that little mini squatted position where she could control her femurs better, particularly on the left side, she was able to, I said, this is the position I want your leg to fall into when you lunge. So she was
Hmm.
able to step out onto the left, let her, kind of not pull her leg into external rotation, an abduction. As it's like kind of just like think about it twisting in as you step on it. And she was able to control the lunge much better. Of course, she had input through
Mm.
the arm, so that was helping the thorax. So again,
Yes.
working both of the drivers at the same time, giving her the control, through the hip, the foot, and the knee, because the knee is the intermediary part. It can be the victim or it can be the driver.
Right.
But what I was trying to do was trying to help her, kind of just through with her movement pattern, get that to start to change. So we did that. And then we did it on the other side too.
Yeah. Yeah.
Um, and because she was able to control her leg a lot better, she was able to lunge onto the right foot without overextending her back. And then and again, helping that thorax stay out of that, right shift so much,
Yeah.
she was able to start to begin to do the lunge on the right without back pain.
Right. And yeah, I
Mhm.
know. I was just going to say, if you just, just treated you being general, the knee, let's say you didn't even look at the thorax and you didn't see it or you
Mhm.
missed it. And if you just treated the knee, you will be limited as to how you can progress the
Mhm.
patient, because that same pattern is going to show up and show up and show up. And treating two of them together, whether it's manually and or exercise progression,
Mhm.
is a must, because you will be limited as to what you can do,
Right.
and if the same pattern keeps showing up and showing up and showing up, she fell onto her knee. She fell
Mhm.
onto the knee. you
Hmm.
know, and to that magnet board, you got magnet board. She's got a lot of magnets on her board, right? So
Yeah.
the knee is definitely a potential driver. You know,
Yeah.
a lot of times we say, oh, the knee's generally the victim, but
Hmm.
not so, you
Yeah.
know.
And then when you know, look at the age group too, when you think about areas where stiffness really starts to kick in, you know, the up the thorax, you know, the CT general area, the knees are, you know, and or hips. But for
Yeah.
her, it wasn't a hip issue.
No,
The hip issue was being driven by the knee and the thorax, you know, so it was just being pulled because that was the position the body was,
yeah,
you know, had adapted and changed into.
yeah,
So it was interesting. You know, so we did wall push-ups with the knees slightly bent so that she could keep her
yeah,
lower part and shift her thorax. We progressed those, and everywhere we went, we worked on bringing her closer and closer and closer to knee extension. But we had to make sure that the thoracic driver didn't pop back in, because as soon as she went into knee extension, she went off on the right side on the
yeah.
thorax.
There's a relationship between those two
Yeah,
regions of the
so,
body.
you know, it just took some time, you know, to really kind of get things to settle down. One of the things that I did, because, you know, she liked walking, but was having a lot of low back pain with walking, was I put two Nordic sticks in her
Oh, that's a great
and I
idea.
said, I needed something to help that thorax, because if she goes off walking, we're going right back into that pattern.
Mm-hmm.
And, you know, it took some convincing, you know, for her to really understand. I said, look, you can walk further with these. I realize that you don't want to walk with them, but your system isn't going to change if we keep feeding into to this pattern. So we have to
Mm-hmm.
change how we're feeding into this pattern.
Mm-hmm.
And so the Nordic sticks actually helped her maintain her thorax better.
Yeah.
And then I told her, I said, just don't force that knee straight. Just let your body do what it's going to do. Just go with it. And, you know, when you use the Nordic sticks, and we remember we were working on that bit of lunging, it kind of
Mm-hmm.
like almost fed into that because she was already holding on to something when she lunged. So then we just
Yes.
started working on those small lunges with the Nordic
Yeah,
sticks,
it's a great idea.
you know,
Yeah.
and coming back and lunging and coming back and stepping out and coming back and stepping out and coming back. So we could turn it into a bit of an exercise program. And eventually what we ended up, you know, getting to, you know, because again, you want to keep, as you call it, loading the drivers. For me, it was more like I needed to wean the input off of the thorax so that she would have to control it with, you know, so because we had, you know, both hands on the Nordic stick, so we eventually went to where we just had the one hand in the right on the Nordic stick and the other on the left, you
Mm.
know, so whenever she stepped out with the left, she had the right, so she had the control, the
Yes.
thorax was
Yeah.
maintained, and, you know, she just got better.
Yeah. Yeah.
And, you know, and eventually she was able to walk without any low back pain, you know, or any
Yeah.
issues. You know, it was easy. As soon as we got her out of the tension created, or I don't know, you know, whether it was coming from the thorax or maybe it was, you know, that was the over recruitment of obturator internus and the lateral hip muscles. Who knows? But as
Yeah.
soon as we took the demand off to where that they didn't have to overwork, that changed things in her pelvis, and it was easier for her to work on some pelvic floor muscle strengthening and, you know, getting her stress urinary incontinence under control, because we were working on both, as we were, you know, we were working on not over recruiting those muscles
Right.
so she would have better control on the left side,
Yeah.
as
Yeah.
well as less pain, because, you know, pain creates that either excitatory or inhibitory, you know, kind
Yeah.
of thing, like either muscles switch off or they switch on too hard.
Right.
And so the
Right.
idea here was to be able to change that
Yeah.
and get that to move differently. And
Yeah.
that's what helped the knee change really over
Yeah.
time.
And it's so interesting. It's easy to say, oh, neural tension, she can't straighten her knee out. But a lot of times, you know, really true neural tension, but
Mhm,
a lot of times it's another region of the body that's causing that
mhm.
person to do that. And that was the case here. So
Yeah.
I think just for the listeners, just, if something's not changing and,
Mhm,
you're, yeah, she had I heard she fell twice,
mhm,
and she's has a right on the knee and she had back pain. And so there's a lot of regions of the body that are on a priority list or a magnet board,
mhm.
but the knee was those are the two things, and the thoracic shift to the right were the two things that were coming up across all the movement patterns that you did. And
Yeah,
you did a lot of
exactly.
them.
Exactly. So when people are talking about having difficulty finding a driver, it's like, look for where things don't change.
Yeah. Or
Or,
get worse.
yeah. And that's why, I thought the foot maybe might be part of the issue. And when we got the foot to work differently, it made everything else worse.
Made it worse.
So,
Exactly.
yeah. So that was like, we had to abandon ship on that one and go somewhere else. But the point I want to make with this is that this person comes in with low back pain. I didn't treat her back. I treated her movement system.
Mm-hmm.
She also came in with a pelvic health issue with stress incontinence. And yes, I did do some intervention. Once we got the movement system to change, then it was easier for her to recruit her pelvic floor muscles much more appropriately.
Yeah.
So it wasn't the first thing I did. I didn't lay her flat on her back and teach her how to do Kegels and then still have her have the issue.
Right. Right.
So sometimes we have to take a look at the movement system and figure out what the priority of the movement system is.
Yeah, the drivers.
To change before we start going to these regions that are screaming for attention.
Yeah.
And I just wanted to bring this case up because I thought it was very, very clear that changing the movement system is what was going to give the changes for her over time, and not doing the same thing over and over again, which is, oh, your low back hurts, it hurts at extension, let's do a manipulation this way. Oh, it's lateral stenosis, let's do a flexion manipulation and kind of free up that nerve and you'll be fine. And kind of going with that predictive model isn't going to serve this person well at all. Instead, it's like, what's going on here? Right.
Not with that history, and I agree with you. I think sometimes, especially with people who've had a long history, and I just had a thought in my head and it escaped, but treating the reason why working on the pelvis or working on recruiting worked better, because you were treating her drivers. Pelvis wasn't her driver. Her knee and her thorax were her drivers.
Right.
So once you treat the right regions of the body, everything else falls into place. If you need to do a little work on recruiting the pelvic floor, you can, but only when you find the drivers. Her pelvis was not her driver.
Yeah.
So anyway,
so I'll just put this out there for the listeners also. Videotape your clients and go back and sit and look. And look at it and just think about it. More will pop up to you. You can't, if you're having trouble, it's because you're probably listening to your inner critic telling you don't get this. And so therefore you're never going to be, you're going to be all crisscrossed when you're trying to look in the heat of the moment. Videotape, photograph, go sit, get calm,
I still do.
Have a cup of tea and take a look at it. Me too, 100%.
Yep.
And I like my clients to video themselves doing a bunch of stuff and send it to me even ahead of time, before I get on. Then we can look at it together and, you get the buy-in right away. In fact, they start saying, yeah, it really looks funny. I was watching myself do that. I'm like doing this and this, and it's like, perfect. So, but anyway, don't underestimate the power of videotaping and photographing. And just really spending a little bit. You don't have to spend hours, just to get in a different place, get something lovely to drink, and just sit in, or have a snack and just sit back and watch. You got to get your brain moved over to Sage so that you can look at this with curiosity and not look at this with that data-driven sympathetic. I got to get this. I don't understand what's happening, but you want to get it into this other. So like move your imposter away, the imposter syndrome and critic away, and just spend a little time with curiosity and take a look at this stuff, and it really so much helps.
Yeah, I agree 100%. I video them every patient, every new patient. I do. Yeah. So, and
sometimes we need to go back and re-video them.
Yes.
And say, what is Sage? Oh, wow, look at the difference here and here. But look at this over here. Now because things unmask.
Yes.
As we move forward too. So, if you're getting stuck, re-video, and just again, get into curiosity and over into that lovely Sage brain and just, spend a little time with it. It'll pop out at you, but if you're like grinding your teeth and gnashing your, gnashing your jaw, you're not going to get this. Because your brain isn't going to make the shift over to like look at it with curiosity.
Yes,
Got to
yes.
get out of that predictive, data driven kind of brain and just like, I'm just going to see what happens here. I
Yep.
may not be able to figure it out right at the moment, but I'm going to at least take them through the movements, see what I can see right now, and then I'm going to really look at this a
Yes.
little bit later.
Agreed. Excellent. Awesome. This was a
Awesome.
wonderful case study. Loved it.
Okay, everybody. We'd love to hear from you, and you know how to reach us. So we will see you in the podcast world and on the next episode.
Next episode.
Thank you.
Bye.